Let's begin. Hello everyone. Welcome back to the series of lectures in nephrology. This is Dr. Maitreyi. So in the past two classes, we have learnt about the basics of fluid and electrolyte balance. We have learnt about hypo and hypernatremia. So in today's class, we will be moving on to the next most important electrolyte, which is your potassium. So we will be starting off the class with hypokalemia. Okay. So let's begin. So let us understand some basics of potassium before moving on to hypokalemia. So we all know that potassium is a predominantly intracellular ion. We know that potassium is a predominantly intracellular ion, right? So the normal potassium levels are between 3.5 to 5 milliequivalents per liter only. Can you see that the normal sodium is 135 to 140? The normal potassium is around 3.5 to 5 milliequivalents per liter. So let us understand the mechanisms of potassium handling. Okay. So this is nothing but your line diagram which you have seen multiple times before. This is your intracellular compartment and your extracellular compartment. Okay. So we know that potassium is a predominantly intracellular ion. So how is the potassium maintained predominantly as an intracellular ion? Right. So this is brought about with the help of this particular pump, which is called as the sodium potassium ATPase. This is your sodium potassium ATPase. So what is the function of the sodium potassium ATPase? It pumps in 2 molecules of potassium and it pumps out 3 molecules of sodium. Okay. So when the sodium potassium ATPase is active, it helps in maintaining the potassium predominantly as an intracellular ion. Okay. Now let us understand the renal handling of potassium. So potassium, as you can see, is reabsorbed in the PCT and in the loop of Henle, whereas it is secreted. It is secreted in the collecting duct and in the distal tubule collecting duct part. Okay. So potassium is secreted in the collecting duct. Okay. So this secretion of potassium in the distal part is under control of what? It is under control of one, aldosterone. We have learned that aldosterone is basically responsible for the reabsorption of sodium and excretion of potassium, right? So this last portion of the collecting duct where the potassium secretion happens is under the control of aldosterone. Then it is dependent on the solute load. Okay. What does that mean? Let us understand with the help of this diagram. Okay. So this is your collecting duct. And now the solute load is more. If the solute load is more, means that the sodium, the distal sodium delivery is more, right? So sodium is a positively charged ion. If more sodium is coming here, the sodium moves inside the tubule, right? So what happens to this portion which is your intraluminal part? I am talking about this portion, right? So the intraluminal part becomes more negative. Now to balance that, what has to come out? Then the potassium begins to come out. Right? So the potassium begins to come out. That is the reason why if the solute load is higher or the sodium delivery is higher, then the potassium excretion is more. Okay, the potassium secretion and removal is higher. Okay, then it also depends on if there is more bicarbonate in the fluid. Right. So if there are more anions in the fluid, to balance that, the cation comes out. So more potassium is secreted into the fluid. Okay. So this is about how the potassium is maintained as an intracellular ion and how the potassium is handled at the level of the kidneys. Alright. Clear till here? Fine. Let's move on to the next concept. So this basically talks about what are the ways in which potassium is handled and what are the mechanisms of hypokalemia. What are the mechanisms or what are the etiologies of hypokalemia? Okay. So before we even move on to this, a very basic sense question or a common sense question, you will know that potassium will be low if the intake is poor, right? So low intake or poor intake. Low intake or poor intake is a definite cause for hypokalemia. Apart from that, let us look at the first mechanism, which is your transcellular shift. So the first mechanism is your transcellular shift. What does this mean? We know that potassium is an intracellular ion. So anything that affects the sodium potassium ATPase, anything that increases the activity of the sodium potassium ATPase, which means what? It's going to push in more potassium intracellularly. So what are those things? One is insulin. When do you give insulin? Insulin is given during treatment of diabetic ketoacidosis, during treatment of DKA. So during treatment of DKA, because of this huge amount of hyperglycemia in 300, 400, we have to give IV insulin, and IV insulin is going to push the potassium intracellularly and cause hypokalemia. Then catecholamines. One very important practical point that you can have hypokalemia is in your inhaled beta-2 agonist. Inhaled beta-2 agonist. Where do you give this inhaled beta-2 agonist? It is nothing but your salbutamol or albuterol, which is used in the treatment of bronchial asthma. Right? It's used in the treatment of bronchial asthma. So, whenever a patient is on these inhalations, salbutamol or albuterol round the clock for an acute exacerbation of asthma, if the patient is having hypokalemia, remember that inhaled beta-2 agonist can cause hypokalemia because of the push of the potassium into the intracellular compartment. Then metabolic alkalosis, and in the treatment of vitamin B12 deficiency. See, when you are giving vitamin B12, what happens? It causes stimulation of the erythropoiesis. So when there is stimulation of erythropoiesis, more and more cells are being formed. If more and more cells are being formed, then formation of the cells require ions and potassium is used up in that. So it can result in hypokalemia. So these are the conditions where you can have transcellular shift of the potassium ion to the intracellular compartment and in turn resulting in hypokalemia. Alright, fine. Then renal losses we will look at separately. Let us understand extrarenal loss. Now we have understood there can be transcellular shift, there can be hypokalemia because of poor intake. Now there can be hypokalemia because of loss, which can be from the kidney or from the extrarenal loss. In the extrarenal loss, it can be because of the GI losses such as diarrhea. Then VIPomas. VIPomas are a type of pancreatic or neuroendocrine tumors where there is excessive secretion of VIP. VIP, as you have learnt in physiology, is vasoactive intestinal peptide, which is responsible for GI motility. So in VIPoma, what happens is that there is increased secretion of VIP, which causes excessive diarrhea, excessive watery diarrhea. Okay. Then presence of drains, post surgery you can have drains which are placed where there is large amount of intestinal fluid which is drained, and intestinal fluid as such is rich in potassium, so loss of that can cause hypokalemia. Apart from that, including presence of fistulas, right? So any GI disturbance can cause hypokalemia. Alright, then a very important, very rare condition but very important condition is your periodic paralysis syndrome. In your periodic paralysis syndrome, there is a mutation of what? There is a mutation of your L-type calcium ion channels. It's not a potassium ion channel defect. It is a calcium ion channel defect which in turn results in a genetic form of hypokalemia. So why is this called periodic paralysis? Because periodically during certain events like during some stressors, infections, or while having a high carbohydrate meal, they can have precipitous fall in the potassium and can precipitate an episode of hypokalemia. When they have severe hypokalemia, they go into flaccid paralysis, and this is what we call as your periodic paralysis syndromes. There are also certain acquired causes of periodic paralysis. Most importantly, it is your hyperthyroidism. Okay, hyperthyroidism. Hyperthyroid periodic paralysis. It's called as thyrotoxic periodic paralysis. Okay, so till now we have understood about the mechanisms of handling of potassium. We have understood what are the causes of hypokalemia, right? So it can be because of poor oral intake, it can be because of transcellular shift, or it can be because of losses which include renal losses and extrarenal losses. All the etiologies till now is clear. Let us look at renal loss of potassium in more detail. Okay, let us understand the renal loss of potassium in more detail. So whenever we come to the renal loss, let us understand the first concept. When do you get a renal loss of potassium? whenever there is increased distal flow. So we have already seen that if there is an increased solute load, or the amount of fluid which is coming to the collecting duct is more rich in sodium, then the potassium comes out like this to compensate for it. So what are those conditions, right? You can have diuretics. We have discussed in our previous session as well that diuretics help in excretion of sodium in water. The fluid which is going to come to the distal tubule is going to be rich in sodium because the diuretics act more ahead of this mechanism, right? So the mechanism of diuretics can be your loop diuretics or your thiazide diuretics, which act at the loop as well as the distal convoluted tubule. So once they inhibit that, then the sodium is going to get excreted out and the fluid becomes rich by the time it reaches the distal convoluted tubule. Okay, fine. Then there are two syndromes that you should be knowing, which is your Bartter syndrome and your Gitelman syndrome. Okay, remember that Bartter syndrome is similar to that of a loop diuretic and Gitelman syndrome is similar to that of a thiazide diuretic. We will be looking at Bartter syndrome and Gitelman syndrome separately in a while. The next mechanism of renal loss of potassium is because of mineralocorticoid excess. We know that aldosterone is responsible for excretion of potassium. So any condition where the aldosterone is in excess, you can have hypokalemia. Okay. So what are those conditions? You have Cushing syndrome, where there is a glucocorticoid excess, but glucocorticoids can have some amount of extra mineralocorticoid activity. So they can have hypokalemia, congenital adrenal hyperplasia and hyperaldosteronism. Okay. Then very important, one ion deficiency which can result in hypokalemia, magnesium deficiency. So always remember a practical point that when you treat a patient, you have identified the cause, you have treated it, you have been supplementing potassium, but there has been no improvement in potassium despite everything, then always remember to replenish magnesium as well, because magnesium deficiency can result in potassium wasting. Okay. Then increased anions in the fluid. We have already seen that increased bicarbonate in the fluid can be associated with renal tubular acidosis. Increased beta hydroxybutyrate in the fluid, which is seen associated with diabetic ketoacidosis. Beta hydroxybutyrate is nothing but a ketone body. So in DKA, more amount of ketone bodies, then the distal fluid is rich in these anions, potassium comes out to compensate, right? Then penicillin. Use of penicillin is also one of the causes for hypokalemia. Okay, so there are three mechanisms of renal loss we have understood. We have understood about how increased distal flow can cause hypokalemia, mineralocorticoid excess, and the presence of increased free anions in the fluid. Fluid means what? The fluid which is going to get filtered out and come out as the urine. Alright, fine. So now we will discuss about Bartter syndrome and Gitelman syndrome, right? So what are the characteristic features of Bartter syndrome and Gitelman syndrome? So I had already discussed that you have to remember this analogy about Bartter syndrome and Gitelman syndrome. Bartter syndrome is basically like a loop diuretic. It acts like a loop diuretic. And Gitelman syndrome is similar to that of a thiazide diuretic. It is similar to that of the thiazide diuretic. Okay. So the characteristic clinical features that you have to remember about Bartter syndrome and Gitelman syndrome is that all of them present with metabolic alkalosis, all of them present with metabolic alkalosis with hypokalemia, So all of them present with metabolic alkalosis with hypokalemia and a normal blood pressure. So this is the characteristic three clinical features that you have to remember about Bartter's and Gitelman syndrome. Okay, so which channel is affected? This is a genetic defect, right? So which channel is affected? So there are two channels. One is your sodium potassium 2 chloride channel. So one is your sodium potassium 2 chloride channel, which is there in your loop of Henle. So which syndrome is that? This is your Bartter syndrome. And if there is a genetic mutation in your sodium chloride channel in your distal convoluted tubule, this is your Gitelman syndrome. So if you remember from your basic pharmacology, the loop diuretics act on which channel? On this sodium potassium 2 chloride channel in the loop of Henle. And the Gitelman syndrome is because of involvement of the sodium chloride channel. Okay, so this is a basic fundamental analogy that you have to remember. Now let us look at the differences. So onset. Bartter syndrome has a neonatal or an early childhood onset. Neonatal or an early childhood onset. Whereas Gentleman syndrome basically occurs in early childhood to teens. So it can happen as early as 6 years but not before that. Fine. So what is the blood pressure? We know that blood pressure in both Bartter and Gentleman is normal. Polyuria and polydipsia is a characteristic feature of what? It is a characteristic feature of Bartter syndrome, such that in neonatal Bartter syndrome, you can also have maternal hydramnios. You can have maternal hydramnios because of the polyuria. This polyuria is not much of a feature in Gentleman syndrome. Why is there polyuria? Because this affects the tubules, right? It affects the loop of Henle. So there is lot of polyuria, hyponatremia, hypokalemia. Urinary calcium. You will recollect from your basic pharmacology that loop diuretics cause what? Loop diuretics cause calciuria, right? So urinary calcium excretion is going to be higher in Bartter syndrome because it is the same channel that is affected, which is not there in Gentleman syndrome. Urinary prostaglandin excretion is also higher in Bartter syndrome. Okay. Hypomagnesemia is a characteristic feature of Gentleman. Next, where will you find nephrocalcinosis? So as we know that the urinary calcium excretion is more in Bartter syndrome. So nephrocalcinosis is going to be more common in Bartter syndrome more than Gentleman syndrome. Okay. So this is your essential differences between Bartter's versus Gentleman. So Bartter and Gentleman are a group of inherited disorders which affect the sodium chloride potassium channels or the sodium chloride channels. Okay, and all of them present with metabolic alkalosis with hypokalemia, and they have a normal blood pressure. Okay, fine. Now, what are we discussing this far? We have looked about hypokalemia, we have looked at the causes. So under the causes of hypokalemia, we have discussed that hypokalemia can occur due to decreased intake, and it can occur due to transcellular shift that we have already discussed. Then it can occur due to losses in the form of renal or extrarenal losses. Under the renal losses, we have looked at the first causes, which is because of increased solute load. The second cause under your renal loss will be your mineralocorticoid excess. Which mineralocorticoid exactly are we discussing about? We are discussing about aldosterone. So from the basics of fluid and electrolyte balance chapter, we have learned that aldosterone is responsible for reabsorption of sodium and water and excretion of potassium, right? So whenever there is an aldosterone excess, what happens? It is responsible for the distal secretion of potassium. So that's the reason why you will have hypokalemia. So what are the characteristic clinical features of which mineralocorticoid excess presents with? So the most important differentiating feature is that this presents with hypertension. So in a patient with young onset hypertension means what? Age less than 40 years of age. Or in a patient with refractory hypertension means what? A hypertension which is refractory to 3 classes of antihypertensive medications. So in a patient with young onset hypertension or in a patient with refractory hypertension, you have to think of mineralocorticoid excess. Apart from that, they also have metabolic alkalosis and they present with hypokalemia. So metabolic alkalosis, hypokalemia with hypertension. This is a stark clinical differentiating point of this mineralocorticoid excess from Bartter's versus Gentleman syndrome. Okay. Now let us understand what are the causes. So what is primary hyperaldosteronism? Primary hyperaldosteronism means that aldosterone is produced in excess. So where is the aldosterone produced from? We know that the aldosterone is produced from the adrenal. Which part of the adrenal? The zona glomerulosa. So any condition where there is an excess aldosterone production from the adrenal is called as primary hyperaldosteronism. Okay. What happens to the renin levels in these situations? So we know that renin is basically responsible for stimulation of aldo, right? So whenever there is a hyperaldosteronism, this is going to cause a feedback inhibition of renin. So in primary hyperaldosteronism, the renin will be suppressed. Okay. What are the causes for primary hyperaldosteronism? Causes are adenoma or adrenal carcinoma. Adrenal adenomas and adrenal carcinomas. Okay. Now, what is secondary hyperaldosteronism? So, in secondary hyperaldosteronism, renin itself is elevated. So, renin itself is elevated, and renin, because it is elevated, it causes increased production of aldo. Right? So, it causes increased production of aldo. So, this is your secondary hyperaldosteronism. So, what are the examples for this? This includes renal artery stenosis or a renin secreting tumor. Fine. So, whenever a patient presents to you with young onset hypertension or refractory hypertension, you are suspecting mineralocorticoid excess. What are the tests that you want to do to understand whether this is primary hyperaldosteronism or secondary hyperaldosteronism? Obviously, you will look at the pH, you see if there is metabolic alkalosis, you see if there is hypokalemia. Apart from that, you will have to look for your plasma renin levels, plasma renin activity, and you have to look for your plasma aldo activity. Right? So, you also have to look for your plasma aldosterone activity and the ratio, renin aldosterone ratio. So, this will be elevated. Your renin aldosterone ratio will be elevated in secondary hyperaldosteronism because the renin is elevated, whereas it will be reduced in primary where aldo is elevated. Okay. So, this is your basic approach. But there can be situations where your aldosterone is normal, renin is also normal. But still you have a picture which is similar to that of a mineralocorticoid excess. Then what is that condition called? Those are these group of conditions. So, in these group of conditions, what are they? That is what we are looking at. One is GRA. GRA is glucocorticoid remediable hyperaldosteronism. So, as the name suggests, it is glucocorticoid remediable. So, what is your basic problem there? There is this enzyme 11-beta hydroxylase which has a transfer with the aldosterone synthetase enzyme. That means what? There is a crossover, there is a genetic crossover mutation between 11-beta hydroxylase and your aldosterone synthetase enzyme. So, what happens is that whenever this 11-beta hydroxylase, which is involved in what? It is involved in glucocorticoid synthesis, is stimulated. Because of this genetic mutation, aldosterone is also stimulated. So, if there is a glucocorticoid stimulation, how do you suppress it? You suppress it by giving exogenous glucocorticoid. So, when you give exogenous glucocorticoid, what happens? This pathway itself gets suppressed, right? So, because of this counter transference, because of this kind of a genetic mutation where there is a crossover between these two enzymes, where stimulation of the glucocorticoid pathway causes indirect stimulation of the aldosterone pathway, when you give glucocorticoid exogenously, so when you give exogenous dexamethasone, then you can suppress this pathway. That is why this is called as glucocorticoid remediable aldosteronism. Okay, so that is your GRA. So, in this, there is no primary problem with your renin production, there is no primary problem with your aldosterone production. We intended to stimulate the glucocorticoid pathway, but because of the genetic mutation, there is stimulation of this aldo synthetase. That is the reason why this is called as GRA. Okay, so this is a group of disorders where aldo and renin and the plasma aldo to renin ratio or renin aldo ratio will be normal. It will be normal. So, that is your first condition, which is your GRA. Second, we have this syndrome called as SAME, which is syndrome of apparent mineralocorticoid excess, which is your syndrome of apparent mineralocorticoid excess. So, what happens here? This is another enzyme defect where you have 11-beta hydroxysteroid dehydrogenase. You will be looking at all of these enzymes when we discuss the chapter on adrenal, but as of now, just remember this much. So, there is a defect in the enzyme 11-beta hydroxysteroid dehydrogenase. which is responsible for conversion of cortisol into an inactive form, which is cortisone. So this helps in conversion of cortisol into an inactive form, cortisone. But there is a mutation here. Whenever there is a mutation with this enzyme, the cortisol begins to increase. Excess of cortisol further causes mineralocorticoid activation. So why is this called as a syndrome of apparent mineralocorticoid excess? Because here also renin aldosterone is not elevated, but because of this genetic mutation, there is an apparent mineralocorticoid excess where the excess glucocorticoid also has mineralocorticoid activity. Alright, fine. So this is basically the group of disorders which we call as your Mendelian causes for hypertension. Right? Mendelian causes for secondary hypertension. We have looked at GRA, we have looked at syndrome of apparent mineralocorticoid excess. Then the third syndrome which can cause metabolic alkalosis, hypertension with hypokalemia, and your aldosterone renin activity is normal, is your Liddle syndrome. So in this Liddle syndrome, what happens? There is a mutation of your channel, which is your epithelial sodium ion channel in your distal convoluted tubule, or the ENaC mutation. Okay. Then there is also another food substance which can cause the similar kind of presentation, which is your licorice. So licorice is basically a plant root which is consumed in different parts of the world. Excess consumption of licorice can also cause a similar kind of problem with metabolic alkalosis, hypertension and hypokalemia. Okay. So to bring things back into perspective, what are we discussing? We are discussing the various etiologies of hypokalemia, under which section we are discussing renal losses. Under renal losses, we have already seen Bartter-Gitelman. The second is your mineralocorticoid excess. We have looked at aldosteronism, hyperaldosteronism, primary, secondary, and if both renin and aldo is normal, what are the rare genetic Mendelian mutations which can cause this secondary hypertension with hypokalemia, which is your GRA, SAME, Liddle syndrome and excessive licorice consumption. Alright, clear till here. The other group of disorders which can present in this way is your congenital adrenal hyperplasia. In this congenital adrenal hyperplasia, there is deficiency of 11-beta hydroxylase enzyme and there is increased metabolite, which is your deoxycorticosterone, which has mineralocorticoid activity and it can cause mineralocorticoid excess. Alright, so till here clear. Now, we have learnt about the different causes for renal losses of potassium. Always remember not to forget the drugs which cause hypokalemia. So, drugs can act via different mechanisms. The first mechanism is your transcellular shift. So, transcellular shift can happen due to insulin, ephedrine, albuterol. We have already learnt insulin, which is given in the treatment of DKA. Ephedrine is your nasal decongestant. Albuterol is given in your treatment of acute exacerbation of asthma. So, all of these can cause transcellular shift of potassium and hypokalemia. Then renal, amphotericin B and topiramate are drugs which basically increase the renal losses of potassium. Then GI, laxatives can basically increase the GI loss of potassium. Okay. So, this is about the various drugs that cause hypokalemia. Fine. Now, we have understood all the etiologies. Let us move on to the various clinical features. So, in the skeletal muscle, what happens is that hypokalemia can cause hyperpolarization of the skeletal muscles. What happens is that this can result in a flaccid paralysis. Okay. Then, cardiac muscle. Because potassium is required for the smooth functioning of cardiac muscles, hypokalemia can precipitate arrhythmias. Then, rhabdomyolysis. As the name suggests, rhabdomyolysis basically refers to the breakage of the muscle, myolysis. So, hypokalemia can precipitate a rhabdomyolysis. Once rhabdomyolysis happens, it can actually cause hyperkalemia. Okay, so this is a very interesting statement that you have to understand. Hypokalemia can precipitate rhabdomyolysis and rhabdomyolysis can in turn cause hyperkalemia. Okay, then potassium is basically required for the smooth functioning of the gut. So, hypokalemia can result in paralytic ileus. It can result in paralytic ileus, where you basically have constipation, you can have loss of bowel sounds, right, and abdominal distension. Ileus basically means that the intestinal movement gets slowed down. Okay, fine. What are the ECG changes of hypokalemia? So you can have broad and flat T waves. So that is the first change, you have flattening of T waves. Then you can have ST segment depression. You can have ST segment depression. Over the course of time, you can have QT prolongation, and followed by which there can be appearance of U waves. Okay, so this is your myriad clinical features which you can find with hypokalemia. Alright, clear till here? Now let's move ahead. So we come to this very scary looking chart from Harrison's, which is your approach to hypokalemia. But we have already understood all the etiologies of hypokalemia, so this chart will become very simple. Okay, so let us begin. So hypokalemia basically is your serum potassium less than 3.5. So you have to rule out pseudo hypokalemia. If this is pseudo hypokalemia, no further workup is needed. Always understand that if the patient is very symptomatic, patient is presenting with hypokalemic periodic paralysis or ileus, then please go ahead to treatment. Okay, go ahead to treatment and evaluate later. Now you do a proper history physical examination, go through the drug list carefully and rule out transcellular shifts. We have understood what are all the causes for the transcellular shifts. It includes insulin excess, beta adrenergic agonists, hyperthyroidism, it is called as thyrotoxic periodic paralysis, then theophylline and so on. If you have ruled out transcellular shift, go ahead and look at the urinary potassium. If the urinary potassium is less than 15, that means very simple, it is a GI loss. It's basically an extra-renal loss. You look at the acid-base status, you see if there is acidosis or alkalosis. If there is alkalosis, it can be due to diuretic use or excessive vomiting. If the urinary potassium is more than 15, then you are definitely dealing with a renal loss of potassium. Fine. Then you have to go ahead and calculate what is called as your TTKG, which is your transtubular potassium gradient, So what is this transtubular potassium gradient? This is given by this formula, urinary potassium into serum osmolality by serum potassium into urinary osmolality. So you have to look at the transtubular potassium gradient, which is given by this formula. If the transtubular potassium gradient is low, that means that it is occurring due to some amount of increased tubular flow or osmotic diuresis. That means that it is happening due to some increased tubular flow or osmotic diuresis. If the TTKG is more than 4, that means that there is a increased distal potassium secretion. Okay, till here clear? So once you have found that there is hypokalemia, you rule out the transcellular shifts, you rule out pseudo hypokalemia, go through the drug list properly, look at the urine potassium levels. If the urine potassium levels are less than 15, you are dealing with a GI loss. If the urine potassium levels are more than 15, look for your TTKG. If your TTKG is also more than 4, then you are dealing with a condition associated with distal potassium secretion, increased potassium secretion distally, which can again be due to different causes. Okay, so once you have found that it is because of increased distal potassium secretion, look at the blood pressure and do a volume status examination and do an acid-base examination as well. Fine. So if the blood pressure is low, look at the acid-base status, right? It can be due to non-absorbable ions. Patient is on hippurate therapy, patient is on penicillin therapy. Also, you look at the acid-base status. So BP is low normal and there is acidosis. Then we are dealing with renal tubular acidosis or some drugs like amphotericin. Okay. So if the BP is low normal and there is acidosis, we are dealing with renal tubular acidosis or drugs like amphotericin. If there is alkalosis, if there is alkalosis, that means that we are either dealing with some diuretic or we are dealing with your Bartter gentleman, because the BP is normal, right? Okay. So if the urinary calcium excretion is elevated, that means what? It's either a loop diuretic or your Bartter syndrome. We have discussed this just now. It's either a loop diuretic or a Bartter syndrome. If the urinary calcium excretion is low, then we are dealing with your Gentleman syndrome. Okay. So till here clear? We have understood up to level of TTKG. TTKG is more than 4. That means that there is increased distal secretion of potassium and there is increased excretion of potassium. Then you look at the blood pressure and the acid-base status. So if the blood pressure is normal and there is acidosis, then you are dealing with renal tubular acidosis or some drugs like amphotericin. Blood pressure is normal and there is alkalosis, then you are dealing with diuretic use or Bartter-Gentleman syndrome. Okay. So till here clear. Now let us look at the next part. Next part is that the BP is high. BP is high means what? Very simple, we have learned we are dealing with mineralocorticoid excess. Right? So you look at the aldosterone levels. If the aldo is high, renin is also high. Aldo high, renin high. That means renin is causing the aldo to be high. That means this is a secondary hyperaldosteronism which can be due to renal artery stenosis or a renin secreting tumor. RST is renin secreting tumor or malignant hypertension. Now, if aldo is high, renin is low, that means what? It is a primary hyperaldosteronism. So that is also very easy. FHH basically refers to your familial hyperaldosteronism. That is a very rare condition that you don't have to remember at this stage. Now, if aldo itself is low, that means what? We look at the cortisol levels. We are looking at something other than aldosterone which is responsible for this hypokalemia and hypertension and metabolic alkalosis. So it can be either Cushing's syndrome. If cortisol is also low, then we are looking at those Mendelian group of disorders which include Liddle syndrome, licorice ingestion or syndrome of apparent mineralocorticoid excess. Right? So I hope we are clear till here. Let me just summarize this once more. So we are dealing with the approach to hypokalemia. We are looking at renal losses. Under renal losses, once you have confirmed it's a renal loss, we look at the TTKG. If the TTKG is more than 4, that means that there is an increased potassium secretion. Then you look at the blood pressure and the acid-base status. If the blood pressure is normal, you look at the acid-base status. If there is acidosis, then you are looking at renal tubular acidosis or drugs like amphotericin. If the blood pressure is normal and there is alkalosis, then you are dealing with your Bartter or Gentleman. Okay. If there is hypertension with metabolic alkalosis, hypokalemia, then you are dealing with something to do with mineralocorticoid excess. Now, if there is mineralocorticoid excess, it can be either primary hyperaldo or secondary hyperaldo. Based on the renin levels, you can differentiate between the two. If both are normal, then you are dealing with the Mendelian forms like syndrome of apparent mineralocorticoid excess or GRA or Liddle syndrome. So, I hope this approach to hypokalemia has become very simple. Alright, fine. Now, let us move ahead to the management. So, if the patient is not in an emergency situation like flaccid paralysis and patient is able to take orally and the potassium levels are between 3 and 3.5, then you correct the potassium using oral potassium chloride. So, 15 ml of KCl, it is given as a syrup. So, this has around 20 milliequivalents of potassium. So, 15 ml of KCl has around 20 milliequivalents of, 15 ml of KCl has around 20 milliequivalents of potassium. So, 40 milliequivalents of potassium actually raises the potassium by 0.5 milliequivalents only. So, 40 milliequivalents of KCl or external potassium raises the serum potassium by 0.5 only. So, let us say that the potassium is around 3. So, it's a very mild form of hypokalemia. Right, so you have to raise it to 3.5. So how much will you give? 50 ml of pot chlor maybe in the morning and 50 ml of potassium chloride in the evening. Right, as long as there are no ongoing losses. Now if the potassium is less than 3 or if the potassium is very severely low and the patient is symptomatic, then please check for the magnesium because hypomagnesemia is a very important cause of hypokalemia. okay, and correct the magnesium. In these situations, if the patient is not able to take orally, and even otherwise oral correction alone will not help. So you will have to give an IV correction. You will have to give an IV correction. So through a peripheral line, the maximum dose is 40 milliequivalents of KCl. This is dissolved in 500 ml of NS and it is given over around 4 to 6 hours. You will have to give the potassium very slowly because of the risk of arrhythmias. Okay. And the maximum dose that you can give it through a peripheral IV line is only 40 milliequivalents because of the risk of thrombophlebitis. Okay. If you are giving in an ICU setup through a central line, then you can go up to 80 milliequivalents at one shot, but you will have to give it over 4 to 6 hours. Alright, fine. So this is about your management of hypokalemia. So with this, we have come to the end of our chapter on hypokalemia. We have understood what is hypokalemia, what are the mechanisms, what are the etiologies, how do you approach, what are the clinical features and the treatment. So I hope you have understood everything and I hope this chapter has become a little bit more simpler. The next chapter we will be dealing with hyperkalemia. Alright.